Well, the other problem is I didn't have one.
Okay. Welcome, everyone. There's a lot going on, so we appreciate your being here. And it is being taped, so if there are other people that you know that can't make it and they want to be a part of the discussion, rather than do a lecture, we thought it'd be a lot more fun just to have a panel discussion that would both involve the panel and involve all of you. And rather than my making introductions that are long and boring, I thought what we would do would be to ask each of the panelists to spend a couple of minutes and talk about what their positions are and their experience with global primary care, primary health care. My name is Steve Berman. I'm the director of the Center for Global Health and a pediatrician. Edwin?
Sure, so Edwin Asturias, I think some of you know me, but I'm a Guatemalan first and then second a pediatrician also with some training in infectious disease and public health, and I spent a lot of time in Guatemala working in not only research but healthcare services, and now I'm back here within the Center for Global Health.
I'm Calvin Wilson. I've been involved in a variety of aspects of global health, almost all in either the primary care or the primary health care arena. Started in Ecuador, where for 9 years we worked to develop the first family medicine training program there, which was primarily primary health, primary care. But along the way, I got involved in a health project in a series of communities that were totally isolated, and that's where I learned about primary health care in all of its various ramifications. From there, went on to work in training the general physicians and nurses in the primary care clinics of Jordan, and then after, again, a short stint here at the university, was involved in Rwanda in helping them to develop all of their specialty programs, but including a family medicine program there, which we specifically tried to orient toward working in the community health clinics of the country. I may have a little bit more to say about that later, but so I've been involved in about 3 different continents in that.
My name is Alejandro Ceron. I am also from Guatemala, and I trained originally as a physician in Guatemala in the 1990s, and part of what I studied in medical school was primary health care. And I was just telling Susan that I remember that when I was in my 3rd year of medical school, one of the tests basically was testing us on distinguishing between primary health care and primary care. Because that was somehow relevant, and I want to say that perhaps if nothing else, you should remember that there is an important distinction between those two, and that some people don't care about that distinction, but that some other people care a lot about it, and have been working on that for 40 years. When I was a medical student, I was very involved in doing work with the community, so to speak, and a lot of that was inspired by primary health care, but in nature was really driven by selected primary care. After graduation, I decided that I wanted to work in rural areas, indigenous areas of Guatemala. That was in the context of the 36-year-long civil war just ending in Guatemala. So there was this moment of hope, but also of a lot of this language of the modernization of state institutions and the reform of the state. So there was a health reform that happened at the time that I will talk a little bit about. So in that context, I started working in a newly created program that was somehow inspired in primary healthcare, and that was funded by the Inter-American Development Bank at the time. There I experienced firsthand the let's say the strengths and limitations of the approach that we were using, and a little bit of the frustration with the limitations made me first join a group of people who were trying to imagine a new way of organizing the health system in Guatemala that was inspired in the Alma principles. And after working with that group for a few years, I decided to become an anthropologist instead of a physician. So I can tell you more about that later too.
Susan?
Hi, I'm Susan Rifkin. I'm a Denver native, which is more than most of you in this room can say, I know that. I did my first 2 degrees in the States, and at the age of 28, I left America and didn't come back for 40 years. So I'm extremely lucky because I have one of the few people left now that have both field and academic experience. So when I left the States, my first 2 degrees are in Chinese studies, which is not irrelevant because the Chinese example was an inspiration for the Alma Declaration, and I'll say more about that later. I was 10 years based in Hong Kong, I started out working with missionary groups, well, Christian groups, they weren't even missionary, talking to people in Christian hospitals about getting out into the community where the real problems were. And one of my mentors was a man by the name of David Morley, who talked about a book of hospitals being the end of healthcare, too many hospitals. And so we went out and worked with these Christian groups trying to get the doctors out of the hospitals. One of the results was we organized a group called the Asian Community Health Action Network, which was composed of mainly doctors, actually. I am not a doctor, I'm a social scientist. Getting these groups together to work more for community advocacy. And that became the foundation of what is now the People's Health Movement, if any of you have heard of that, which is a very strong international advocacy group for promoting the key principles of primary health care, equity, and community participation. After 10 years in Hong Kong, where I got my PhD, I came back to Britain, and I was there, used that as a base for some years. But I was so lucky. At the time I went back, I became a consultant for the WHO and to their hierarchy, the people who were implementing primary health care. So I worked at the late 80s and then in the early 90s at WHO while primary health care was trying to be implemented. And I can tell you some of those stories. Went back to London, ran a course for primary health care for the London School of Hygiene and Tropical Medicine for 9 years. I'm still attached to them. I worked at LSE where we set up a global policy on mainly low and middle income health countries. I helped set up 2 master's programs, one at the University of Heidelberg in Germany, the other in Kenya at Kisumu, which has now become the Great Lakes University. And now I'm an old lady, and I just go around and have a good time and talk to people about primary health care.
Great. So, this is, our session is scheduled for an hour and a half, but we know that some people will be leaving in an hour. So what we're going to do is we're going to get through, I've got a whole list of questions. We're going to have a primary responder and then give other people an opportunity to respond if they want to. We'll go for about 30 minutes, and then we'll open it up for questions, and then we'll take 20 minutes of questions, and then we'll go back and ask some of the other questions that we've put together. So the first question is really for Susan. Susan, what's so important about this Alma Ata Declaration?
So important, Steve. It's the way health and health should be seen for everyone. The Alma Ata Declaration, signed 40 years ago, and which we're celebrating today, was really an agreement by the 134 nations at that time of the World Health Organization to work globally to look at a way in which health has been seen and delivered. And it was revolutionary. What came out of the Alma Ata Declaration was a view of health which was not based on doctors or hospitals and medicine, but it was based on social justice and the determinants of health, the social determinants of health. And that vision, agreed to by the members of the WHO, began to shape the way we look at health today. And I know now courses in this department at this university have to look at equity as part of what they deliver in their courses. When I got into this 40 years ago, social scientists were neglected, right? Who listened to a social scientist? That changed with HIV/AIDS when doctors couldn't solve it. People could, there was neither cure nor prevention. So what it has done has moved the dialogue of health and how health improves into one which talks about social justice, equity, and community participation. And these are key elements of the Alma Ata Declaration and what is primary health care. Now, you can have a definition of primary health care.
We're going to get to that.
Okay. That's what's revolutionary.
And I want to kind of expand, and before I open it up to more of the three of you, one of the key elements of Alma Ata was that everyone has a right to health care. I mean, I think that was the first time, right? I learned that from Susan. But the issue is, and this is for Alejandro, how do we expect low and middle income countries to implement the concept that healthcare is a right when the United States has consistently rejected that and continues to reject the concept of healthcare as a right? Alejandro, could you talk a little bit about the perspective, especially in low and middle income countries, of what does healthcare as a right really mean?
Yeah. So let's see, the discussion about whether or not health or healthcare should be a human right has been around for more than 100 years, and it somehow consolidated in the Universal Declaration of Human Rights, which then led to the two international treaties that give legal force to international human rights. One of those treaties is the International Covenant on Social, Cultural, and Economic Rights, social, economic, and cultural rights, which was adopted in 1966 and has been ratified by most countries in the world, but not by the United States. So there is something problematic about considering social, economic, and cultural rights actual human rights, in this country, which has championed the idea of human rights throughout the world. So that to me is something really puzzling. And when I talk about this with my students, they are, I don't know, they have all sorts of reactions. So, but coming from a country that was in the middle of a civil war when I was born in 1975, and that was coming to the end of the civil war when I was in medical school, I very much value the idea of international human rights because it was in part thanks to the internationalist solidarity movements that were driven by this idea of international human rights and social justice, that some windows started to open in Guatemala that eventually led to the end of the civil war and then to trying to build something new from there. Part of what happened during the civil war in Guatemala is that the Guatemalan state became very efficient at controlling people, disappearing people, massacring people, but not very good at providing and organizing, institutionalizing education or health. So this really powerful idea of health being a human right has become one way of bringing the need for social policies that address health and the social determinants of health to discussions in Guatemala. And of course, there is a lot to work on still, but just having at least formally, the idea that health is a human right settles a lot of conversations in Guatemala, because everybody, including people who are really right-wing, they have to start by acknowledging that health is a human right, and from there we can talk and try to build whatever we want to build, public, private, whatever. But that's a very important starting point. Something that should come from our conversation today is that we need to think of health and healthcare in terms of system or systems, maybe interlocking systems. And something that we often don't think enough about are the values that underlie health systems internationally, but also in different countries. So if there are countries or societies where a value is that health is a human right, that just drives the conversation in a different direction than a country where you not only don't acknowledge that health is a human right, but you basically say that health is a commodity.
So, Edwin, Cal, I might ask Edwin, the concept of ratification of Guatemala, of the Alma, the recognition that health in its broadest term is a right, you think it had much impact in Guatemala? Alejandro thinks it did. I'm not sure. Did it?
Well, I think it did within, the healthcare system, because I think people that were in the healthcare system for the first time had a framework that sort of justified what many of them have been working for a long time. I can say that at the level of the university, national university, there was a lot of effort of doing primary healthcare and introducing new concepts of primary healthcare. I think at the level of the Ministry of Health, even as much as it was sort of subjugated to the army and the processes there, still there was an interest in sort of delivering primary care to populations in need. But I think coming back a little bit to why Alma, even though it was a sort of great vision and concept, really hasn't translated completely into a different healthcare system, and even in the United States, is because in many ways most of healthcare is, in a sense, at the mercy of the economic system. In the few countries in the world where that system is not subjugated but is interdependent, where basically it has become a more interaction between an understanding between the economic and the healthcare system, that without good health, the wealth of the nation is not going to be better. Is because those countries have gotten into that dialogue and that understanding early on. And I think in the United States, it's a great example. I mean, there's still here a huge amount of ignorance about how much is costing the United States, the inability to provide healthcare for all in a universal way. And you are willing to pay double the amount of any other country in the world for worse outcomes. So for me, it's clearly an economic decision, and one that is actually costing this country probably its future. But you can say the same about any other developing country where that happens. So I think when you get to countries like European countries, or not go too far, Nicaragua, or countries where Cuba, where they have understood that healthcare is a right, but also a great sort of a safeguard and promoter of development. They have gotten to a population that is quite healthy, or in better health conditions, just using primary care and part of the concept of Alma. So, but Cal,
and I mean, you've had experience in Rwanda especially, but Jordan, and to what extent has Alma in the countries you've worked with been a real turning point?
It was a real turning point. I started working in Ecuador basically only a few years after Alma was published, and I could see the changes in health policy as they occurred over the 10 years that we were there. There was constant reference made to it. It was held up as the gold standard for development of healthcare policy at that time by most people. I think we realize that healthcare discussions are usually politicized in some way, and even in Ecuador, there was a major divide between the common people who really wanted Alma to be implemented, and the very wealthy who really had some concerns about that and weren't quite as excited about it, mainly because they already enjoyed good health care. They could pay for it. So that was an issue. In other countries like Rwanda, the same thing happened. They really took to the declarations and even the fine print in the Alma Declaration to help develop their own health system. And to this day, I think that there are many elements of it that show very clearly how some creative thinking can lead to very effective implementation of elements of primary health care.
So there's primary health care and there's primary care. Okay. One's much narrower, right? If you look at the countries, and Edwin alluded to them, that we think have been most successful in making the vision of Alma Ata a reality. We've got countries that did it in a very, I'm even going to say, repressive, controlled way, which would be Cuba and Nicaragua, in a sense that they dealt with the economic conditions in a certain way which made it possible to develop really robust health care systems, not primary care systems, with the resources that they had. But there were other countries like Argentina and Costa Rica that that within a more open system have really been able to develop really good primary health care. So the question, Susan, is, well, how did countries really take the approach to go from primary care to primary health care? And what's necessary at a country level to have that broader approach?
You know, my experience is more in Asia. That's where I've worked, you know. And I can tell you, this is my take on it, Steve, and it's an interesting take. The countries that have done well with primary health care, India, Thailand, Brazil in Latin America, there has been a change in governments. Not necessarily, you know, the Chinese did it by revolution, but, you know, the Indians voted out Congress. The Thais, the rural doctors rose up and forced the government out, and Thailand has one of the best primary health care systems, right? Brazil is teetering. I mean, we won't talk, but when it did set up and it had that coup against the military, and they had the more, quote, progressive, they have one of, again, a very good primary health care system. So I think what makes it work is a change from those in power who see health care as a major driving force and don't take account of what the people need, and ones where you have changes in those governments that allow that to happen, and there's been more success there.
Other comments, Alejandro? What do you think?
What do I think?
It sounds like Susan's saying you need a political revolution almost, not necessarily violent, but you need, in order to really have a government change course in terms of primary health care.
But I want to say that not necessarily through a revolution, but through some sort of new social contract. Like somehow a society decides, you know what, health is a priority, we need to figure this out. Once that becomes one priority, then and you start trying to turn that into policy programs, education and medical education and everything else, then you plus you are able to institutionalize that in the different institutions that are somehow playing a role there. Then it survives changes in government, and that gives it the sustainability that it needs. And one of the hallmarks of primary healthcare is that it tends to be when implemented more sustainable and also more efficient. Like in terms of cost efficiency. So if you're not thinking short term, like I need to vaccinate 95% of the children, for that, you can do it almost however you want to do it. But if you want to sustain that, then building a system that is somehow implementing a primary healthcare is a more efficient way of doing it. And I would say that the Costa Rican example is probably the one that I see there as being the one that kind of drives my answer.
So, Cal, did Rwanda need, or was Rwanda able to overcome its genocide and disaster and recognize that they had to do something for people? Is that why the commitment to healthcare and the current society of Rwanda has been successful and sustainable?
Yes, a very short answer. Absolutely. I want to go back just a minute, though. In my introduction, I tried to make the distinction between a good part of my career being devoted to what I call primary care medicine, and almost a conversion experience to understand the importance and role of primary health care. And I think it might be good to try to make the distinction here. Primary care is very often defined as simply the provision of health care at the first point of encounter. And in most people's minds, that has to do with either a general physician or perhaps some sort of ancillary healthcare worker, like a clinical officer, like a nurse practitioner, and in many countries, including Rwanda, they consider it to be a nurse, just a regular nurse that can provide that. Basically, the big difference is that primary care is a very medical concept, and it focuses on the diagnosis of illness and the treatment of illness. Primary health care, on the other hand, is much broader and really draws many of its concepts from the social sciences, where a big element, a major element now, especially of primary health care, is an understanding that illness is caused by, in many respects, problems that have to do with various determinants of illness, both social, economic, environmental, and so on. And so if we're going to provide health care, we have to deal with those elements as well. Other elements have to do with especially the social elements of it. We're beginning to recognize this in our own country here, where we realize that for instance, a state of chronic anger, which has to do with your social interactions, is not a very healthy lifestyle. And there's actually attempts made to begin to deal with that, as just an example. So I hope that's. Would you add anything to that?
I would only add 2 quotes. Sorry, I don't want fake news. This is from the WHO, so I'm going to quote these things to you. The Alma Declaration promoted primary health care as its central means toward good and fair global health. Not simply health services at the primary care level, though that is important, but rather a health system model that also acted on underlying social, economic, political causes of poor health. And the other one is the commission which they set up in 2008 called the Commission on the Social Determinants of Health. On the back cover, and I nearly brought the thing with me, but the back cover of it is the statement, reducing health inequities, and that's different than inequalities, and I can tell you why, is an ethical imperative. Social injustice is killing people on a grand scale.
So Edwin, what's the difference of that broad definition and population health? How does because population health is in vogue, is there a difference between the vision of Alma Ata and population health?
I think what population health you define as basically the distribution of, in this case, health and illness in groups, right? So you understand for first time you're not talking anymore about an individual, but you're talking about how those diseases and those sort of the health, the wellness and health of the people are distributed within a group. And because that's a key concept for population health, it tells you that you can measure things individually, but they don't make sense unless you measure them as a group. And I think for me that I'm more involved now in population health, it's very clear that population health is a bit of the mission and the mission and vision, as well as the eventual measure of that vision and mission in a population, or how we're going to deal with that community or group. And primary healthcare is the vehicle of how you're going to get there. I mean, if you think about you ever going to get to population health, I think we all here probably agree that there's no other way but primary healthcare. And I just want to add one concept, and that is, because I think primary healthcare is, sometimes we physicians react a little bit to the concept of primary healthcare, because it's when we bring social determinants of health and bring the causality of disease into play, we feel a little bit unable to deal with illness. But one thing that we physicians understand is we actually are very good at sort of deciding or getting instructions how we should operate within the healthcare system. And one thing that we haven't done very well, and you can see it here in the United States as well as countries that do not incorporate the Alma concepts into their framework, is that they should tell that the objective of any hospital system, for example, should be to disappear as a hospital. So if you sort of ingrain in people the issue that if I'm working at Children's Hospital Colorado here, my objective should be to make every effort that Children's Hospital disappears as an institution, I will get the concept of primary healthcare, because then I will make every effort for every patient to sort of go to primary healthcare and to sort of make sure that primary healthcare is reinforced at my own sort of risk, right? And if you get that concept, of course, if you think about it, hospitals will never disappear. But their intention and their continuous strategy should be to sort of reinforce primary healthcare.
So I have one last question before I open it up. And 40 years ago, primary healthcare was infectious disease, malnutrition. Now, it's lifestyle diseases, right? Diabetes, heart disease, kidney disease. And so the concept of primary healthcare being lifestyle medicine has changed. Cal, what does this all mean?
Well, it has changed, and it in the more developed world, it I think implies a variety of things that we have already begun to see. As an example, heart disease is one of the most common causes of death in the developed world. Actually, in the undeveloped world, but I'll get to that in just a minute as well. But it's one of the most common causes of death. And so you find that doctors, even cardiologists, although they do their magic with technology and often achieve some remarkable short-term results, cardiologists are finding themselves spending more and more time in counseling. Counseling regarding diet, lifestyle, and that kind of thing. That was not the case when I started medicine. The counseling of a patient was really limited to how they're supposed to take their medicines, and that's it. And so we're beginning to recognize that lifestyle issues are some of the significant determinants of health and need to be addressed. There are other determinants of health, too, that need to be addressed that maybe we could talk about later. But I think we find that the world has changed significantly in its concept of primary health care in a variety of ways. Let me just list a few here. One is that we have a lot more effective tools of dealing with illness now. Some of these tools really need to be applied on a population-based level, such as vaccinations, for instance. One of the more common causes of death in older people used to be pneumonia. It was called the old man's friend. With vaccinations now, we can change that dynamic. Now, we're still going to die, but it's probably going to be less likely that we die of pneumococcal pneumonia. So we have different tools. The other thing that has changed, I think, in the past 40 years is I think we have a little bit more nuanced view of what is required for good health across the board, and especially related to the various modifiable and some non-modifiable causes of illness. The other major issue that I see, especially not just in our country, but especially in lower income countries, is that the expectations of the people have changed in terms of what they want from healthcare. I'll take China as an example. China led the way with the development of barefoot doctors in terms of trying to institutionalize some form of community health worker. And they were extremely effective in specific areas. But they're gone now. Why? Because the Chinese people began to realize they appreciated what could be done, but they wanted a higher level of care. And so the institutions have had to change to produce health workers that still work at the community level, but provide a much higher level of care. I see that in Latin America, in many different countries, where villages that were overjoyed to get a community health worker 20, 30 years ago are now wanting a doctor. Now, they don't quite know what kind of doctor or anything like that, but what they know is that the community health workers can only do so much, and they want more. So the expectations that have come over time have made a big difference with that as well. This, I think, means that the implementation of primary care is going to have to change as well. And I'll just throw out my own bias in this, and what I've been working on for the past several decades is trying to educate the primary care physicians, specifically generalists, general practitioners, family physicians, even like I was in Rwanda working with clinical officers, in Africa working with clinical officers. They have to be able to deal with an increasing number and scope of problems in a very competent way to be able to meet the needs and the demands of healthcare at a community level.
Great. Okay, let's open it. Any questions? And I've got a lot more questions if you don't, but right here.
Yeah. Okay. So I have a couple, but I'll just start with one. So when I talk about Alma Ata in my classes, I often talk about it in the context of independence movements for a lot of former colonies, just because of the timing and what was leading up to Alma Ata. And just wanted to get your thoughts about kind of the colonial imprint on low and middle income countries and the extent to which it's necessary to break free from that to actually be able to implement primary health care, and how that has continued in terms of their development approaches, because I do think primary health care is ultimately health and development together that allows it to happen.
Great. Could you just give your name and
Sure.
position
Yes.
so that everyone knows who's asking questions?
Yeah. I'm Meredith Fort, and I'm in the Health Systems Management Policy Department and in the Centers for American Indian Alaska Native Health.
Great. And is there anyone in particular you want to address your question to?
Well, I think really anybody who'd like to answer it.
Well, I'd like to come back on that.
Okay,
Yeah.
so we'll let Edwin and then Susan.
You know, I will hope, one will hope that Alma Ata was sort of brought with that purpose, but I think it came at a moment that it truly was a reaction towards vertical programs that we had, in the past. So I think there was a clear recognition that our aims at controlling malaria through a vertical program, establishing family planning programs to reduce population, and you can count almost any program that WHO and the countries were doing at that time were tremendously vertical. And I think Alma really was set up to sort of break away from that vertical system and create a more horizontal system, which I think, as many of you, of my colleagues here have said, it produced an important impact in how health systems started to rethink the way. Not to say that in the late or mid-90s to 2000, we've seen a comeback to vertical programs, especially driven by HIV and other epidemics that we have had, and even chronic non-communicable diseases are experiencing sort of a little bit of the same. And so I think there is a second wave now looking at primary healthcare, and that's what probably the reinforcement of primary healthcare is coming in the new declarations, because clearly, again, we have relearned that vertical programs have a limitation. And in my framework, when I used to sort of work with the Ministry of Health in Guatemala, I used to say to my peers there that vertical and horizontal programs always have a place in a healthcare system, but the aim of any vertical program is to convert itself into a horizontal program, not to remain vertical. Unless this is something that you can eradicate. So that's
Susan?
I think we've missed a really important point of all that we're not having a discussion about, which is community participation. So much of this has been on the medical and the delivery of healthcare services. What has changed a lot in what's put forward is the role of communities, what people think. So, and I could challenge you to say, get rid of that hospital. There's a strong medical profession that's going to fight that. So I think what has broken a lot of the discussion is now it's not we simply tell people what to do, but if we're going to get any good effects and effects at the local level, it's because people who go in have been brought into that conversation. You can tell people as long as you want to, this is what the way you should behave. And they're very nice and say, thank you very much, doctor. Where does it change? It changes when it meets their concerns and the way in which they see to go forward in health. So that whole community participation bit, so the colonial thing, if you want to talk how the colonial was broken, it was a lot about people's movements, and they were revolutionary movements. If we can go back to see what's happened in different countries. But in health, the change has been that you now have to look and work with the people who are your intended beneficiaries. You're not going to get very far.
That's right.
So Alejandro, I want to pick up this as an anthropologist in your experience. Everyone admits that community engagement and community empowerment are critical to success and sustainability. But what you find is when you try and do that at a national level, it's very hard to do. And it's top down. And we see it in the United States, right? There's nothing more community participatory than schools and how people in the United States view their local school board and local school activity, and any attempt to bring a sense of equity across or consistency is fought. So I guess my question for you is, what are the challenge? How do you overcome the challenges to having through community engagement at a national level?
Yeah, let's see. There are a couple of things that I think that the Alma Ata Declaration also brought to the table that we need to keep in mind in this discussion. And one of them has to do with this idea of understanding the systems that contribute or not to generate or to produce or to the social production of health. And a couple of things there. One is that one should challenge the notion that there are lifestyle diseases as public health diseases, because usually those lifestyle or so-called lifestyle diseases are really part of a system that somehow drives people to one or the other thing. And yes, we always have individual agency, right? But there are systems, and when we could think of food systems, for instance. Food systems, you need, and we keep learning more and more about the political economy of what is available and what is not, and how that frames or shapes even our culture. What do you have for breakfast, and where does that come from? Sometimes it comes from an industry that somehow made it very easy for you to eat cornflakes and milk instead of whatever else that maybe you would be eating if your family traditions had I don't know, survived, right? So there's that systemic piece, which also ties with the international relationships. So for instance, in Guatemala, after the Civil War, there was this health sector reform, and that health sector reform was, putting together, designing that health sector reform brought some of the people who had been doing a lot of really good work, both with vertical programs and also with some ideas of primary health care, of horizontality and integration. But the reform was shaped and conditioned by Inter-American Development Bank loan that basically said, you will get this money, but you have to basically weaken your institutions, including the Ministry of Health. You need to weaken your capacity to regulate anything, and you need to externalize as much as you can, meaning you have to use public funds to buy whatever you can buy from the private sector, be it laundry for public hospitals, or medications, or specialists. So what happened with that? But then again, it had embedded the idea of social participation. So when I worked in one of those programs, I was going to the communities and trying to promote participation, but I was already framed with what sort of stuff we could talk about. And I remember, and I was 24, 25 years old, and I remember doing that work and realizing, what am I doing here? And I came across this book from the 1980s about local systems by the Pan American Health Organization that talked about participation and the distinction between utilitarian participation and empowerment in participation. And I thought, my God, this is exactly what I am doing wrong. And then I brought that up to my supervisor, and they were going to fire me. I learned later, and they did not fire me because one of the new management people who was brought, who is a community nurse, by the way, she thought that my ideas were interesting, and she asked me, let's bring those concerns and let's put them in practice. We couldn't, because we were framed by this way how the reform was. So in the end, there are those systemic frames that shape the way how social participation can happen.
I'm sorry, I didn't get to enough questions. Next question? Yes.
This is kind of question, comment, and
Your name, please?
Yeah, I'm Victoria Seligman. I'm in the Departments of Rheumatology and Internal Medicine, and I'm a director of a international volunteer program that focuses on capacity building, particularly in Cambodia. So most of my experience is based on my work in Cambodia and Southeast Asia. So, and that, Alma also, it sounds like at best has served as a sort of framework, and there's some shining examples. And the work that we've done with health volunteers overseas in Cambodia has certainly been very successful in terms of capacity building, bringing up physicians' knowledge base, which you had alluded to as one means of success, and in Rwanda. So Rwanda had the benefit of having a government that's supportive of health systems improvement. In Cambodia, that type of approach is non-existent, and there is no healthcare for all or primary care or, to say it mildly. And, there's very disparate movements that come from the nonprofit world primarily, for example. So I guess my question and comments are really surrounding where does Alma Ata stand now in terms of how do we as a global community, in terms of creating future frameworks, incorporate accountability, and what's Alma Ata next generation? Because we've been talking a lot about these shining examples and that have the social context to succeed, and my experience has been the contrary. So,
Susan, you want to go first?
Yeah. This is a very difficult world, and one that we're living which is very unstable and kind of terrifying. What's happened to Alma Ata at the moment, and they reaffirmed it October 25th back in Anschutz, Kazakhstan, is a focus on universal health coverage. The idea is this is where this will be our equity issue. So what we're going to do is get governments to provide health care for all people. There's been a lot of, as you can imagine, a lot of opposition to this, and for two reasons. One is just the practical reason. Where are poor governments going to get the money to do this? And if you look at the expenditure of those low and middle income countries now, in many cases, 1.5% of the GNP goes to health. Where are they going to get it? Donor aid could help. Donor aid has been drastically cut from 3 years ago, and we've got statistics on that. So who's going to do this? Second question is, if you look at the Asante Declaration, lots of talk about people-oriented, people-centered healthcare, right? Equity is a big issue, huh? But the other question on universal health coverage is who benefits from this? Where are the social determinants? Where is community participation? Even they could sign up, so where has this gone? And if you go back to the history of the policy, you see one of the reasons they have focused on this is because in 2010, in WHO and the international economic community, there was a reflection of the 2008 financial crisis that came into WHO and the UN. And what they were struggling with was how can we get people to support this vision of primary health care when we don't have examples that are strong enough to show how it works? What can we get people to unite on? And universal health coverage sort of became a theme. WHO in its 2010 World Health Report talks about how we get performance, health systems performance, if you will. So I think we're in a very, very complicated, difficult period right now. And what's going to happen through Asante, and this is now universal health coverage, sustainable development goals. Number 3, health. It's the only one out of 17. Universal health coverage, very big there. So it's unclear is the question.
Edwin?
So let me put a different take on it, because I think Alma Ata and Asante, if you see it, there hasn't been much variation. I mean, a bit of variation and more, people-centered concepts in the new declaration. But turns out, I think we're very clear about what needs to be done. I mean, that's no question, and also we're quite clear on one of the hows, which is primary health care. I don't think there's a debate on that, and people that sort of know health systems know that that's the way, and know the way exists. But I think where we have faulted all of these years, all of these 40 years, is the language that we speak for advocating for primary healthcare. And what we haven't done very well is to speak the language of the system that is actually, that we are at the mercy of, and that's the economic system. So if you don't talk to the people that drive the economic system of each nation and tell them what are they losing with not using primary healthcare and universal healthcare, you'll never get that. So I'll give you a practical example. The Trifini area, which is this rural southwest area of Guatemala where we work, has these communities that are very poor, and there's a lot of economic development through agriculture there. And one of the major employers there has been very concerned and wants to sort of improve the health of the population, and it wants to improve their living wages. What we have discovered is a concept that now I think we should be speaking a lot, which is, turns out that they pay better than any other employer there, but the people are still poor. And they say, why am I paying better and people continue to remain poor? And one of the major reasons is what we call medical-induced poverty, which is 60% to 70% of what these people invest in healthcare comes out of pocket. And so every time that a child or a woman or even the worker becomes sick, they have to go and put 70 to 60% of that healthcare cost up front, which means that they're going to be in debt for the next 6 months to 2 years. And that will never, there will be no paycheck that ever catch up with that process. So because this is one illness, in 2 months there's another child that is ill, in 6 months there's another person that gets ill in the family, and it's a vicious cycle. So unless you talk to the productive system and say, this is what you're losing. If you had a safety net where basically these people could go to and could get these basic healthcare needs taken care of, you wouldn't worry about the salary of these people, because the salary of these people would go much beyond what it is going right now. So I think we need to sort of change the way that we measure things and how we present them to the economic system in order to sort of get the right answer.
Cal, you're at the board, so I know that you've got something to enlighten us with.
Well, I want to take Edwin's last comment. We've got to know how to present this to people. And let me show you a way that I think it can be presented. It's based on actual studies done and repeated and validated, actually here at the University of Colorado, over several years. It's sometimes called the ecology of healthcare, and basically various very interesting studies have shown that if you take 1,000 people in a community or in a setting, a population of 1,000, and follow them for a month, what happens in terms of their health? Well, within a month of those 1,000 people in a given population, 750 of them will suffer some sort of illness problem. Now, that can be anything from a simple cold to a major heart attack. But most of them, 3/4 of them, will actually, in 1 month, actually have some sort of illness. But the studies have shown that of the 750 that experience some sort of illness, only about 250 of them actually seek medical care in a primary health care clinic, in an urgent care clinic, whatever they happen to have available. What happens to the other 500 people? They get better. I mean, most illnesses is self-limited. Or they talk to their grandmother. Or, in other countries, they go to a traditional healer, and they get something, and they get better. So, one of the first things we need to keep in mind is that of all of the people that actually get sick, only 1/3 of them actually need or feel that they need a healthcare worker of some sort. Now, this is the important thing right here. Of these 250 people that actually search for healthcare in the United States and Canada, only about 15 of them need a hospital. Specifically, only about 15 of them really need high-quality specialty care. Now, what is it that drives healthcare in our country? This is 15 people, right here. And when anyone thinks about the cost of healthcare, this is what they're thinking about. They're thinking about the dialysis. They're thinking about the heart transplant. They're thinking about the kidney transplant. They're thinking about multiple major surgeries and all of that kind of thing. But that's a small percentage of the overall population. The realm of primary health care actually involves this group here, primarily in terms of education, and this group here in terms of dealing with the most common problems. And I think if we keep this in mind, I think it helps a lot for us to understand that our perception of the economics of healthcare is totally distorted. And we need to watch for this. Many countries, many of the poorer countries know this. And they actually put most of their money in this element and in this element here of primary care and primary health care. And they do very well with that. And they end up spending a heck of a lot less than we do.
If I may add just very, very quickly in response to, I forgot your name, but Victoria's question. I agree with everything here, but just to add to what Edwin was saying, one of the challenges that we face when we work in countries where there is not that social contract that says health is a priority is that we still want to do something, right? So what ends up happening is that a lot of churches, NGOs, medical education missions or whatever, do what they can with the best of intentions. And what I want to argue is that we should be careful and really thoughtful in asking ourselves. And I say this as someone who worked for church clinic and also for some NGOs. We should ask ourselves, are we helping strengthen the health system or are we not? Because if we don't think systemically, we cannot achieve what Edwin was saying. It is more expensive. Nobody can do that. It has to be a societal effort. So that doesn't answer your question. It just complicates it, right? What am I doing when I go there? Am I strengthening or weakening the system?
Yes.
Okay.
Your name and position.
I'm Ji Ying Yu. I'm a faculty member on the campus Department of Medicine and working in the Division of Renal Disease and Hypertension. I'm a full-time statistician, and so I'm so interested in the number you saw there. So just before you mentioned education, so important. I graduated from medical school in China, and after I got my PhD in biostatistics in the US, and I got involved in some study project that using health education as a tool, whatever purpose. So when you talk about education in the population, what exactly you mean? So education delivered to the population or to the physician or both? If both, which one should take the priority?
Cal, do you want to respond first?
Well, in this example, I was trying to point out that the education really needs to go first to the population, I feel. And frankly, it's education of the population that I think has led to some of the tremendous improvements in health statistics that we see in the developed world. Because just for the doctor to be able to say something doesn't necessarily mean that he's going to be getting through to an individual patient. You really have to educate the masses, I think, and then allow the doctor to reinforce that education on a one-by-one basis. So I think it really needs to go to the population through mass media types of methods.
Edwin, did you have something?
Well, no, I will just reinforce what Carl was saying, and I'm just going to give you an example. I think for many, many years, Latin America has been shown as a model of, for example, vaccination, and how people in Latin America have been not only successful about, introducing new vaccines, but keeping and eliminating, vaccine preventable diseases. That's the field that I work on the most, and that's what I'm bringing the example. And somehow it's sort of always thought about, the Latin American population just accepted vaccines, but there was a huge effort by Pan American Health Organization as well as countries to really continue to educate the population all the time about vaccines. You see completely different example here, where we have thought that the education through physicians to the population would be enough to carry out effective vaccination delivery. And what we have learned is that if we leave it to the physician, then people will find ways of educating themselves in the internet and other places, which actually had led to less coverage in this country. So, and you still, to this date, don't see a strong effort by the CDC, nor by the Department of Human Services, to sort of do any major education campaign on vaccines in this country, even though we're having a tremendous amount of problem with vaccine preventable diseases. So there your example about education of the population comes first.
Okay.
Yes.
Hi, I'm Johnny Williams. I'm a student in the HSMT department. I just had a question. Should you plan like the morals or the ethics of a country to increase their buy-in to, I guess, have universal healthcare coverage? So like with America, you would produce like an economic example versus like a moralistic one?
Susan, that sounds like it's in your territory.
Oh yeah, that's right.
Would you please, I don't quite get what you want. Sorry, could you do it again?
Yeah, so like, for instance, to get a country to increase their buy-in to providing universal healthcare coverage, should you plan like an economic incentives if they're more economically driven, or should it be more ethical if they're more like a more ethical country, I guess?
Guess what? You can't fix it. I'm telling you, you can't fix it. There's no, and I do want to say this about how we look at what works and what we don't works. Is so often we're looking at, I'm sorry, Dr. Thing, but we look at random case control studies, right? Which shows it's a linear thing. It tells us how many people did what. It doesn't tell us why or how. And we have to move out of that evaluation. Vaccination being a really good example of this. We are now coming up with new frameworks to do this. One is called realist evaluation. Another is called implementation research. People have discovered that it just doesn't, knowing how many people do it doesn't tell you how it works. So it's ethical. You've got to know how people think and why they're doing this thing. And I've become quite keen. Meredith and I, in fact, are working on an evaluation now for Guatemala to try and shift the groups that have been there. They kept looking at how many mothers breastfed. I gather, I don't know Guatemala and I don't speak Spanish, but I did learn that mothers don't tell you those things because it's very, personal. They're not going to tell you that. So unless we get other ways of looking at evaluation and figuring that out, we're going to be caught in this whole thing about trying to fix it. You cannot fix it. Well, they've got to fix it.
Let me just say from my standpoint, I think it's both. Public policy is always both. And the reason that it is because it has the two components, and also because the population itself, in some way, we just have to accept, especially in this divided country now, to accept that there are not two kind of people, but certainly there's a group of people that think more about economics, and there are some other people that think about society in terms of equity and ethics. Not that the people that are in the economics don't think about ethics, but they see the world through the economic focus, and there are others that we see the focus through the equity and justice sort of focus. And if we accept that both arguments have a say in the public policy, then we should make both arguments. So if you just do the economic argument, you may end up with people that don't feel disenfranchised because the equity and justice arguments are not there. And if you just do the justice, the people in the economic world will say, this doesn't make economic sense. So you have to do both.
And if I just may add,
sure.
and human beings, especially societies, are so complicated and contradictory because the economic argument has been made for decades that the US is spending more money than the outcomes that it's getting. And still, there will be some way how decision makers, and maybe you and I, somehow think that it's better to keep doing it that way, even if it's not efficient. So, I don't know. We're complex species, I guess.
I'm reading Meacham's book, The Soul of America. And if you're interested in that question, I'd really recommend that book. And the reason is that it really talks about the importance of leadership at critical periods of time. And it deals a lot with the racial issues of America. And it shows that in order to deal with the moral and ethical and social justice in countries, you often need someone who is really respected in leadership positions, who is able to create a constituency for change because that person is respected and isn't viewed as being corrupt. And that leader doesn't have to be a political leader. It can be a Susan B. Anthony for women's suffrage. But doing the right thing, and I think it's true, Nelson Mandela, it's true across the world, you have to have someone that's respected to lead. And I think The Soul of America really brings that out. Yes.
So I'd like to ask the expert panels a question and get your help. The first thing I want to cite, WHO website, the Elemental Declaration was the first recognition of the role of traditional medicine and its practitioner in primary health care by WHO and its member states. So my questions to you are, does Colorado healthcare system need traditional medicine, and how? The question was asked by Tuesday Wasserman, a Caucasian woman, direct a two-tiger clinic in Boulder. So she has been practicing acupuncture, including several years in New York City, in a big hospital, in a team with a PhD acupuncture specialist, and to help patients with stroke for recovery. So when she come back her hometown in Boulder, she really found the difference. So she wondering, for opium epidemic, acupuncture can help, but how this tool can be adapted by Denver Health and the CU Health System. So she thought about a research project.
Could you?
Yeah.
Okay. So Cal?
I think the way you're describing this, there may be a little confusion between alternative medicine and traditional medicine.
Okay.
I think in the Alma Declaration, a lot of the acceptance or the positive mention of traditional medicine included a wide variety of elements, which did include some alternative medicine type things like homeopathic medicine or Ayurvedic medicine in India, or acupuncture and some of the traditional methods in China. But it also included, for a significant part of the world's population, traditional practitioners that basically combine the innate feeling that health is somehow connected with the spiritual world. And so they approach what they do by communicating with the spiritual world and calling on the help of the spiritual world. All of that to say that I think that one needs to look at the various elements of this, and I'll just give my bias. I think they all need to be subjected to scientific scrutiny. There are acupuncture, for instance, had a bunch of various very high quality studies done, and it's been shown to be effective in certain areas. Same thing's true of chiropractic. In some areas, not all, but some. Whereas others have been shown to not be any real different. That gets into the whole realm too of traditional medicines, herbalists, and that kind of thing, and that requires, I think, intensive scientific study, because there are, I know for a fact, just from my own experience, there are a host of traditional plant-based remedies being used in various continents that are highly effective, and we need to get those into the mainstream. So I don't know if that answers your question or not. It's a mixed bag.
If I may, last year I participated in the technical meeting organized by the Pan American Health Organization dealing with traditional and alternative medicine, and there were representatives there from Canada, the US, and most countries in the region. It is complicated, right? But one of my lessons after participating there is, first of all, it is a reality. Whether or not Denver Health acknowledges it exists, there are alternative and traditional practitioners in the Denver area, and people are using them. Second of all, what is traditional medicine here may not be traditional but alternative elsewhere, right? So Chinese medicine may not be traditional in most of the US. So it gets complicated. So for instance, a lot of indigenous healing traditions from the Americas are traditional, and because of that, are traditional to the places where they were generated, and where there are people who consider that to be an integral part to their cultures and their identity. That kind of medicine needs to be treated differently than other types of alternative medicine. But then in the end, what all these forms of medical systems need is they need to organize and advocate for whatever they want in different societies, because Denver Health cannot regulate acupuncturists. Denver Health could, at some point, reach out to acupuncturists and have a conversation with them, but are they organized to talk to Denver Health? That was the key to the discussions that we had at that meeting. When in countries where there is some form of organized group of practitioners, they have been successful at getting their practice be recognized and implemented, even sometimes by public health systems. But if they are not organized, then it just makes it impossible.
I'll give you just one example of that. The Indian Health Service. Many of the Indian tribes here in our country have very traditional views of health and illness, the Navajo especially. And after some discussions, the newer hospitals now being built by the Indian Health Service of the U.S. Actually include a room in them in which the floor is totally dirt, which is a prerequisite for their ceremonies to take place. And somebody that's too sick to be discharged from hospital can actually be brought to this room and still have the medicine man do his ceremony. In other words,
it's respected. It may not be felt to be, the effectiveness is a whole other question, but at least it's respected. And it's not only permitted, but they make allowances for it.